Hello everyone, and thank you for joining us for our webinar today. My name is Kristen Reed, and I am a research coordinator with Health Evidence. It is my pleasure today to welcome you to our monthly webinar series. Today we will be discussing support interventions for breastfeeding mothers with healthy-term babies. Our presenters today are Alison McFadden and Anna Gavine from the School of Nursing and Health Sciences at the University of Dundee in Scotland. Welcome to you both, and thank you for joining us today. We would also like to wish a warm welcome to all of our health evidence users who have joined us for this webinar as well. So throughout the session today, we will be posting polling questions through the WebEx platform. Your participation in these questions is voluntary and anonymous. And I'm just going to leave the consent slide up here for a moment to give you a chance to read it over, and then I will move on shortly. Okay, so just to let everyone know that after today, the PowerPoint presentation and the audio recording will be made available on Health Evidence's YouTube and SlideShare accounts, usually within the next week or so. And the links to both of these resources will be posted in the chat section now, so you can access them later. So today we are very excited to be talking about the review, Support for Healthy Breastfeeding Mothers with Healthy-Term Babies. The link to the Health Evidence Review page for this systematic review will be posted in the chat section. So you can click on this link and follow along in the review using the article full text or PubMed link out, and we'll also post the direct link to the full text article in the chat box. So just a few housekeeping items before we begin. Please use the chat section in WebEx to post your questions or comments. We ask that you send your questions or comments to all participants and not just to the host. Also, please feel free to send your questions and comments throughout the session. So towards the end of the session, we will try to save some time for the presenters to respond to any questions or comments you might have. For the best connection, we do recommend that you use a wired internet connection versus a wireless. And should you have any connection issues, we have posted the 24/7 WebEx helpline on this slide, as well as in the chat section. For your audio today, please listen through your speakers. If you are having trouble hearing, you can go to Communicate at the top bar in WebEx and then click Audio Broadcast. So we have our first polling question of the day, which can be found on the right-hand side of the WebEx platform. And we're really just wondering how many people are joining us today. So are you watching it with just yourself, in a group of 2 or 3, 4 to 5, 6 to 10, or over 10? And once you've finished responding, please make sure to press Submit at the bottom after you've selected your response. So I'll just leave that up for a couple more minutes. I think the majority of people are joining just with themselves today, but we do have a few groups of 2 to 3 and a couple also of 6 to 10. So that's great to hear. Thank you for joining us. So while we let those come in and finish up a bit, I would like to give a special thanks to our Health Evidence team who have worked to bring this session to you today. There is a large team of us who work to keep Health Evidence current and maintained, as well as to coordinate our monthly webinar series. For those of you who may not be familiar, Health Evidence is a service and research organization involved in knowledge translation for public health professionals that was launched in 2005. Our main product is a comprehensive registry of reviews where we provide over 5,000 quality-rated systematic reviews evaluating the effectiveness of public health and health promotion interventions. The main goals of Health Evidence are to make evidence relevant to public health more accessible and make it easier for professionals to use evidence in decision-making. So really the value add for using Health Evidence is that we save you time. We have done the work to screen and appraise each review within our registry. We screen all reviews for relevance to public health and keep our repository up to date by constantly screening relevant databases. At any given time, we are no more than 1 to 2 months behind the publication date. So we've done the work for you by critically appraising all reviews through a transparent process whereby you can actually click on the full quality assessment for each review and see our rating for each of our 10 assessment criteria. The Health Evidence website also has various tools and supports for evidence-informed decision-making available online, and many of our users have informed us that our tools and repository are both easy and simple to use. So I'm just going to touch quickly on the model for evidence-informed decision-making, which we can hopefully keep in mind as the presenters go through their systematic review today. So this model consists of 5 components that you can see in the diagram. And traditionally, public health practitioners and decision makers consider evidence about community health issues in local context, existing resources, and community and political climate in making decisions about programs and policies. However, it has become apparent that considering evidence about research can be challenging to integrate into public health practice. And as such, the Health Evidence webinar series is really designed to highlight research evidence relevant to these public health decisions. So on this next slide, we can see the stages of evidence-informed public health, and it illustrates the steps involved in evidence-informed practice. So this wheel is a guide for practitioners and decision makers to determine how to address a particular issue by systematically incorporating research evidence into the decision-making process. So there are 7 steps that you can see outlined here, and today we'll be focusing on how the presenters have worked through the first 4 of these steps in order to help public health decision makers with the remainder of the steps in this process. So I'd like to ask our next polling question, and we're really wondering how many participants here today have heard of or are familiar with PICOS. And again, please press submit after you've selected your response. So I think we're getting several responses in right now, and we're about at half and half. So about half of people have heard of PICOS before, and half have not. So while that finishes up, for those of you who aren't familiar, PICOS is a way for you to structure your research questions. So it involves defining who the population is that you're interested in, what the intervention, program, or service is that you want to know about, the comparison group, if any, and outlining the specific outcomes you are looking for. Sometimes we also have a particular setting in mind, which we can also state here, for example, school or community setting. The value of a PICO question is that when you have an issue that arises, you can use PICO to turn this into a searchable question, which allows you to further articulate specific components of the question, and then can help you to search for relevant information related to your PICO more easily and efficiently. So our last polling question that I'll put up here before we get started and pass over onto our presenters for today is how often do you use systematic reviews to inform a program or service? So is it something that you use always in your work, often in your work, sometimes in your work, or never? Or we do have an option as well if you're not entirely familiar with what a systematic review is. So please, please let us know, and thank you for responding. We're getting a lot of responses in across the board, but many are definitely always and often, as well as a very good proportion of sometimes and a few as never. So thank you for responding, and that's great. So as that finishes up, without further ado, I will move on to introducing our presenters. We're really excited to have Alison McFadden, a Senior Research Fellow and the Director of the Mother and Infant Research Unit in the School of Nursing at Health Sciences at the University of Dundee, as well as Anna Gavine, a Research Fellow also at the School of Nursing and Health Sciences at the University of Dundee, today to present this systematic review. So I will pass it along to Alison and Anna, and thank you very much for both joining us today.
So, good afternoon or good morning. I'm Alison McFadden and I'm really pleased to be here to do this presentation, and alongside me is my colleague Anna Gavine. So we're going to be doing this presentation between us. I'm going to start by giving you some of the background of the review, and then Anna will take over and talk about the methods. I suspect that a lot of you will already know why breastfeeding is important, but I think it's a good idea just to recap on some of the important issues. So we know that breastfeeding has a fundamental impact on the short, medium and long-term health of children, and also an important impact on women's health. For children, we have good quality evidence in all settings that not breastfeeding contributes to mortality due to infectious diseases, hospitalization for preventable disease such as gastroenteritis, respiratory disease, and otitis media, and there are increased rates of childhood diabetes, obesity, and dental disease. We also know that not being breastfed has an adverse impact on intelligence quotient, or IQ, and educational and behavioural outcomes for the child. I haven't provided all the references for these, but they are all in the background of the systematic review if you want to have a look at that after the presentation. For women, there is also good quality evidence that not breastfeeding is associated with increased risks of breast and ovarian cancer and diabetes, and also that the lactational amenorrhea that's associated with exclusive or predominant breastfeeding increases birth spacing, and this is particularly important when other forms of contraception are not available, such as in many low-income countries. It's also important to note that for many of these health outcomes, there is a dose-response relationship, and that is you get the greatest benefit resulting from breastfeeding exclusively with no added food or fluids for around 6 months, and with breastfeeding continuing as an important component of the infant's diet for at least 2 years. And the negative impact of not breastfeeding has been demonstrated in a range of settings and population groups, though the balance of risks and benefits varies from setting to setting. So, for example, gastroenteritis is likely to result in a much higher mortality in low-income countries. And just to recap on the World Health Organization recommendations for breastfeeding that were first adopted in the WHO in Young Child and Infant Feeding Strategy in 2003, and that is that breastfeeding should be initiated soon after birth. It should continue exclusively until 6 months of age, and then continue as an important part of the infant's diet until at least 2 years. However, we know that worldwide these targets are not reached. Breastfeeding rates have to be interpreted cautiously because there's a lack of standardized indicators, especially in high-income countries, and so comparisons are difficult. However, in general, there is an inverse relationship between the wealth of a country and the rates of breastfeeding, so that the higher the wealth of the country, the lower the rates of breastfeeding. So amongst high-income countries, we find that certainly in some countries, there's a marked decline in breastfeeding after the first few weeks, and there are low rates of exclusivity up to 6 months and of continuation beyond 12 months, although obviously there are variations from country to country, with, for example, Scandinavian Nordic countries having much higher rates than the UK, the United States, etc. In low and middle income countries, we generally have much higher rates of breastfeeding duration than in high income countries. However, there are very variable rates of exclusive breastfeeding for 6 months, and the world average is only 37%. So moving on to breastfeeding support, which is the topic of this review, and first asking the question, why is it needed? Well, the low rates of breastfeeding, and especially of exclusive breastfeeding, suggest that there are barriers and that support is needed to help women overcome these obstacles. These barriers can exist at a societal level, for example, a lack of paid maternity leave or support for breastfeeding in the workplace, or poor attitudes to breastfeeding in public spaces. Or the barriers can exist at the health system level, such as many health professionals are lacking the knowledge and skills to support women to breastfeed or to overcome problems such as mastitis or poor milk supply, poor positioning and attachment. In some settings, there's routine separation of mothers and babies after birth, which of course does not facilitate breastfeeding. And then we have barriers at the individual level where women may encounter problems, complications with breastfeeding, their families may be unsupportive, or they and their community may have cultural beliefs that don't support breastfeeding. In countries where breastfeeding rates are low and breastfeeding tends to be hidden, many women lack the confidence in the adequacy of their milk supply to meet their baby's nutritional needs. So in terms of support, what do we mean? Well, support is a complex intervention which should address the multifaceted barriers that I've just spoken about to breastfeeding. And for example, it might encompass information or education, for example, to dispel some of the myths around breastfeeding. Support may include teaching women skills to manage breastfeeding, positioning and attachment, and solving any problems that they come across. It may be more psychological support, as in building confidence and self-esteem. It may be practical support, such as helping with other tasks like housework so that the mother can focus on breastfeeding. And it may be social support, that is creating supportive networks, helping women to identify who might be their best support person in their own social milieu. And breastfeeding support interventions can be provided by different people. They may be health professionals or lay people. It can be provided in different settings, in hospitals or in the community. It may be provided to groups of women, or it may be on a one-to-one basis. It may include not only the mother, but family members, typically fathers or grandmothers, or it may be targeted at wider communities. It may be offered proactively, or it may just be available if women ask for it. And it can be provided face-to-face, by telephone, or through social media. And support interventions may only involve one contact or regular ongoing contact over several weeks or months. But unfortunately, breastfeeding support is often poor and inconsistent, and we know that many women don't receive good support that enables them to breastfeed. And that can often be because there's a lack of recognition by policymakers and those who commission health services of how important breastfeeding is, and therefore there's a lack of investment in resources. And in many health settings, the health practitioners lack the knowledge and skills that they need. And before moving on to the details of the review, just to put it in a global policy context, that we were asked to update this Cochrane review as part of the UNICEF and World Health Organization update of the Baby-Friendly Hospital Initiative guidance, which is being updated this year and hopefully will be published soon. So they're looking at the guidelines on the patient care, and which you may well know as the 10 steps to successful breastfeeding, and on implementation guidance for national programs. The update actually involved updating 21 systematic reviews on the 10 steps, of which this is one. So I'm now going to hand over to my colleague, Anna Gavine.
So our review had 4 objectives that are listed here. The first was to describe the forms of breastfeeding support which have been evaluated in controlled studies and the timing of these interventions and the settings that they were used in. The second objective is probably the most important one, and that was to examine the effectiveness of different modes of offering similar supportive interventions. And we were looking at things like whether the support was offered in a proactive or reactive manner, face-to-face or over the phone. It also considered things like whether the interventions contained both antenatal and postnatal components. And for objective 3, we looked at the effectiveness of different care providers and where the information was available on different types of training. And the final objective aimed to explore the interaction between background breastfeeding rates and the effectiveness of support. So I'm now just going to talk you through the methods about how we did this. So for those of you that aren't aware, Cochrane systematic reviews are often considered one of the gold standard forms of Cochrane systematic reviews. The Cochrane collaboration was founded in 1993 and they've now published over 6,000 systematic reviews, many of which have informed national and international health policy. So as all systematic reviews do, this review has an inclusion criteria, and the inclusion criteria sets out exactly what studies we would include in our review. So in terms of study design, we were including any randomized or quasi-randomized trials, including cluster randomized trials. And cluster randomized trials, by that I mean instead of individuals being randomized to receive the intervention or the control, communities or hospitals would be randomized instead. In terms of the participants, we included healthy women who were either considering or intending to breastfeed healthy babies. And by healthy women and babies, we mean those that didn't require additional medical care. So for example, women with diabetes, women with HIV/AIDS, overweight or obese women, or women that were requiring surgical care. Studies which specifically focused on women with these additional care needs were excluded, although we do recognise that these are important populations as well, but separate Cochrane reviews are looking at their breastfeeding in these groups. In terms of the actual intervention, we had a very broad inclusion criteria. We included any form of support to women that was supplementary to standard care. So support could include things such as praise, information, and the opportunity for mothers to ask questions. It could also include staff training to improve supportive care given, because as Alison said earlier, one of the big issues is often insufficient training for staff. In these interventions, the support could either be offered by healthcare professionals, so that could be midwives, obstetricians, lactation consultants, or it could be lay people, including peers. We included interventions that provided either one-to-one care or group care, and these interventions could be delivered in any setting, so things like hospitals, primary care centres, other community locations, church halls, or in the women's home. We also included interventions where the support was delivered over the phone. The interventions could be proactive, and by that we mean that the person providing the intervention contacted the woman. Alternatively, they could be reactive, and by that we mean that the woman actually had to ask for support. The woman did obviously have to be breastfeeding in order to receive the support, so we included interventions that were provided in the postnatal period and excluded interventions that were provided in the antenatal period only. However, that being said, these interventions could have an antenatal component to them. So to give you a little bit of context to this review, we had to do this update very, very quickly. So we focused on 4 primary outcomes, and they were stopping any breastfeeding before 4 to 6 weeks, stopping any breastfeeding before 6 months, stopping exclusive breastfeeding before 6 weeks, and stopping exclusive breastfeeding before 6 months. Previous versions of the review did include stopping any or exclusive breastfeeding at other time points, so 2, 3, 4, 9 and 12 months. They also included measures of neonatal and infant morbidity and measures of maternal satisfaction of care. But because of the short time period that we were operating in, we focused on these primary outcomes. I should also probably say that a new set of core outcomes for Cochrane pregnancy and childbirth breastfeeding reviews are currently being developed. So hopefully by the time we update this review again, we'll be able to use them. So in terms of the search strategy, we're quite fortunate being part of the Cochrane Pregnancy and Childbirth group, because unlike other systematic reviews where you need to develop your own search strategy and search databases yourself, the Cochrane Pregnancy and Childbirth group has actually created a database of all available reports of all controlled trials related to pregnancy and childbirth. And they do this through searching databases such as Medline, CINAHL, and hand searching journals and conference proceedings. 2 members of the Cochrane Pregnancy and Childbirth group then allocate each report to a topic area. The list of all reports in the topic area relevant to the review is then provided to the review authors. So in the case of breastfeeding studies, anything that the Cochrane Pregnancy and Childbirth group come across that's related to breastfeeding gets kind of coded as breastfeeding, and then anyone doing a Cochrane review on that will be given all those articles to screen. So as this review was last updated in October 2011, we examined all reports published between then and February 2016. And this resulted in 162 new trials, and we retrieved those and we independently screened each of those by 2 authors. Any disagreements were resolved by discussing with a 3rd author. We didn't have any restrictions on language, and when non-English papers were identified, the Cochrane Pregnancy and Childbirth kindly organised translation for us. This is just to give you a bit of an idea about what the data extraction looks like when you're going through a Cochrane review. This is a screenshot from RevMam, and we took the data from the studies and put it into RevMam. And we got data on the characteristics of the participants and the interventions. That was generally quite straightforward to do. The main challenge here was getting the data into a format that we could use for the meta-analysis. For those of you that haven't done meta-analysis before, what you need for that really is just the raw data. However, often authors don't provide that, so you need to work backwards from the statistics provided or contact study authors for more information. This was all double-checked by 2 authors. The next stage in any review is an assessment of the risk of bias, and because it's a Cochrane review, we use the tool developed by the Cochrane collaboration, the Higgins Risk of Bias tool. And again, this was assessed independently by 2 reviewers, and we would compare what we found and discuss any disagreements. So for those of you that aren't familiar with risk of bias assessments, the Cochrane tool helps you judge whether a study is at high or low risk or unclear risk of bias across the following domains. The first one is random sequence generation, and what you're asking yourself there was the method that the patients were randomized to groups actually truly random. So did they use something like computer random number generator or even coin tossing, or was the sequence generated by non-random means? So by that it might be something like an order or even birth date. The next domain is allocation concealment. So we were looking at whether allocation could have been foreseen and therefore manipulated in any way. So we're looking for things like centralized randomization procedures or the use of consecutive sealed envelopes to be classed as low risk of bias. The next domain was blinding of participants and personnel. So this refers to whether the participants and the staff providing the information or other healthcare providers knew whether they were receiving the intervention. You can imagine in a study of breastfeeding support, this is quite a difficult domain to achieve a low risk of bias because of the nature of the intervention. The next domain was blinding of outcome assessment. So this looks at whether the people collecting the data on outcome assessment knew which group the participants had been assigned to. The next domain is incomplete outcome data. So this looks at how many participants dropped out and if this varied between groups. As a rule of thumb, we considered nutrition of 25% or over to be high risk of bias. And then we've got selective reporting. So this involved checking that the study authors reported all the outcomes that they said they would look at, and they weren't omitting results. And the main way to do this was to check against the original study protocol when available. And finally, other biases included things like looking at baseline imbalances, or in the case of our review, issues to do with clustering or contamination of the intervention. And finally, once we'd completed the meta-analysis and the risk of bias assessments, we carried out the grade profile. And this basically allows us to assess the quality of the evidence. GRADE was developed by the Grading of Recommendations, Assessment, Development and Evaluations Working Group, and it helps you make a systematic and explicit way of making judgments about the strength of the evidence. Basically, it looks like things like study design, risk of bias, the amount of variation in study effect sizes, the generalizability of the studies, and the actual size of the effect size. Taking all this information into account, an overall score of high, moderate, low, or very low quality is then made to each outcome. I'm going to hand you back over to Alison now, who's going to discuss the results of the search.
Okay, so as Anna said, we assessed 163 reports and we found 31 studies, new studies that met our inclusion criteria. Just a reminder that this is an update of an existing review. So with the additional 31 studies that we found, the full review now consists of 100 studies, which involve more than over 83,000 mother and infant pairs. So by any scale, this is a large review. 73 of those studies contribute data. So there are many reasons why studies might not contribute data, such as Anna has described how sometimes the data that was available to us wasn't in a form that we could use. So we will talk mostly now about the 73 studies that contributed the data. And of those, 58 were individually randomized controlled trials and 15 were cluster randomized trials. So looking at the overall study settings and participant numbers, so we had trials from all country income settings. There were 4 trials in low income settings of 326 women, and they were from Bangladesh, Burkina Faso, Uganda, and the Democratic Republic of the Congo. There were 4 trials from lower middle income countries involving 2,534 women and babies, and they were from India, Kenya, Pakistan. There were 8 trials from upper middle income countries, and they involved 22,477 women and babies, and they were from Belarus, Brazil, China, Iran, Malaysia, Mexico, Turkey, and South Africa. And there were 11, there were a lot of trials from there must have been over 51 trials from high-income countries, of which 20 were from the United States and 8 were from the UK. Other countries were Australia, Canada, Denmark, Croatia, France, Hong Kong, Italy, Netherlands, Singapore, and Sweden. So a wide range, but over half from high-income countries. The characteristics of the participants in the included studies, so most of these were from healthy general healthy populations, and of course, as Anna explained, we were only including studies of healthy women and babies. For 28 studies, which were from high-income countries, the participants in the trials were from low-income groups within those countries. We also looked at the background rates of breastfeeding initiation, and consistent with what I said at the beginning about the inverse relationship between country income status and breastfeeding rates, we found the same things. So all the studies with breastfeeding initiation rates of less than 80% were in high-income countries, and all the studies from low-income countries had breastfeeding initiation rates of over 80%. So just to give you some characteristics of the interventions, with this many studies, there's a lot of variation in the interventions, so we can't really go into detail, a lot of detail of all of them. But the level of the intervention, so in 64 studies, the intervention was received by women. In 8 trials, the intervention was education of healthcare practitioners, and 1 trial evaluated a policy of providing breastfeeding support groups. In terms of other characteristics of the interventions, so in 63 trials, the intervention was proactive, that is, it was offered directly to women, and in 8 it was reactive, that is, women had to ask for the support. In 58 trials, the intervention was provided on a one-to-one basis. In 2 trials, it was provided to groups. In 1 trial, it was offered both as group support and as one-to-one, and in 1 trial, it was offered to couples. In terms of the people providing the support, in 49 studies, it was by professionals. In 15 studies, it was by lay people, and in 9 studies, it was a combination of both. And in 50 studies, the people offering the support had had additional training, but that training was very variable, and in many cases was not particularly well described. And finally, in 38 trials, the support was offered face-to-face. In 4 trials, it was offered by telephone only, and in 30 trials, there were both face-to-face and telephone support. In 49 of the studies, the intervention was only provided postnatally, whereas in 25 there was an antenatal component as well as the postnatal support. And in those trials that reported the intensity of the intervention, there were 24 trials with fewer than 3 contacts, so 3 or fewer. There were 21 trials with 4 to 8 contacts, and there were 17 trials with more than 9 contacts. And then the control group care, in 6 trials, in 29 studies, the control group care was not specified, or it was stated to be standard care but wasn't described. In the remaining studies, there was some description of control group care, and in 6 studies were undertaken in baby-friendly hospital initiative accredited settings. But of course, it's important to note that standard postnatal care varies both between and within countries, and care may have differed within the study period and may also have differed from that which is offered at the present time. I'm now going to hand you back to Anna to talk about the risk of bias in the studies.
So this figure here gives you a kind of visual summary of the risk of bias assessments for all of the studies in the review. And if you just kind of look at it, you can see that the risk of bias is generally quite mixed and unclear in quite a lot of the studies. for random sequence generation and allocation concealment, about half of the studies we judged as low risk of bias there, so that was quite good. But unsurprisingly, where there was issues was to do with the blinding of participants and personnel, and no studies were judged as low risk of bias here, and that's just because simply it wasn't possible to blind the people delivering the intervention or the women receiving it. You might wonder why it's graded unclear in some studies, and that's because the studies themselves didn't state explicitly whether blinding had taken place or not, so they were judged as unclear. The high risk of bias, these studies explicitly said that blinding wasn't possible. Blinding of outcome assessment data, this was made more difficult because in a number of studies the outcome assessment was actually carried out by the women themselves because it was self-report questionnaires. And because the women are aware of the intervention, if they're the ones completing the questionnaire, that puts them at low risk of bias. So the studies where, high risk of bias. So the studies where you've got low risk of bias, it's where there was actual blinded healthcare, or not healthcare providers, blinded study staff going in and speaking to the women and asking them about it. Incomplete outcome data, which is the attrition bias. Most studies scored either low or unclear risk of bias for that, and that was just because of issues in reporting of that. And the selective outcome reporting were big issues there because most of the studies didn't actually produce or provide links to protocols where we could actually see what the predefined outcomes were, so it just wasn't possible to judge that. The biggest issue related to other biases was to do with clustering studies, the studies that were cluster trials. So I'm now just going to go through the results. So first of all, the primary findings, and then the subgroup analysis as well. The first thing we're going to speak about is stopping any breastfeeding at 4 to 6 weeks. A total of 33 studies, including over 10,000 women, looked at this outcome. And because our meta-analysis is so big, the forest plot's actually quite large, so I wasn't really able to fit it on a slide, but you can see the actual forest plot if you go into the actual review itself. And what we found here was there was a significant difference between the groups, with women not receiving support being 13% less likely to be doing any breastfeeding at 6 weeks. When we took out the studies of risk of bias for allocation concealment, the ones that we judged for being at high risk, the difference was still significant, although the effect size very slightly reduced to 0.88. So that would equate to 12% less women. In terms of the grade quality here, this outcome was judged as being moderate quality, and this was because of statistical heterogeneity, suggesting variance in the effect estimates. We didn't downgrade because of risk of bias in any outcome because the sensitivity analysis was robust. That was when we took out the studies at high risk of allocation concealment. For those of you that don't know what statistical heterogeneity is, it is something that we can measure, and there's a value for, and cutoffs that we use. The cutoff in this review, I think it was about 80% heterogeneity. This meant this was judged as high. Now, it's perhaps unsurprising that this has come back as being high heterogeneity because of the huge variation in the interventions. So we explore this further in our subgroup analysis. So stopping any breastfeeding up to 6 months, again, we found a significant difference between the groups, with women not receiving support being 9% less likely to be doing any breastfeeding at 6 months. Again, when we took out the studies at risk of bias for allocation concealment, the difference was still significant, although again, the effect size did reduce slightly. Again, the grade profile quality was moderate quality, and again, it was because of this heterogeneity, suggesting variance in the effect estimates. The next outcome was stopping exclusive breastfeeding at 4 to 6 weeks, and this is the outcome where which demonstrated the largest effect sizes. So again, there was a significant difference between the groups, with women not receiving support being 21% less likely to be exclusive breastfeeding at 6 weeks. When we took out the studies at high risk of bias, the difference was still significant, although the effect size reduced very slightly to 0.8. in the studies that were at low risk of bias. So that reduces the number of women breastfeeding from 21 to 20%. Again, the study was downgraded in the grade profile to moderate quality because of this heterogeneity. And then effect of the intervention on exclusive breastfeeding at 6 months. This was measured by a total of 46 studies, so it included over 18,000 women. And again, there was a significant difference here between the groups, with the women not receiving support being 12% less likely to be exclusive breastfeeding at 6 months. Again, when we took out the studies at high risk of bias, the difference was still significant, although the effect size reduced, in this case, to 0.93 in the studies at low risk of bias. Again, the grade profile was downgraded to moderate quality because of statistical heterogeneity. So to explore this heterogeneity, we did a number of subgroup analyses to try and unpick what was maybe causing the differences. Because when I say the interventions are heterogeneous and there are effect sizes, what I mean is that some studies are showing very positive effects and some studies are showing less positive effects. So we're trying to unpick what are the things that make studies or make the intervention effective. The first thing we looked at was who was delivering the support. And as Alison said, most of the studies were delivered by professionals. This imbalance in these subgroups makes comparisons a little bit tricky. What we can say from this is that exclusive breastfeeding at 6 months, there was a statistical difference which supported interventions delivered by lay people. And for cessation of any breastfeeding up to 6 months and exclusive breastfeeding at 6 weeks, there was a suggestion that larger intervention effect sizes were associated with studies delivered by lay people. However, we're not confident in these results as the number of trials and interventions delivered by lay people is much smaller than those delivered by professionals. In terms of the type of support, we compared face-to-face support with telephone support and also telephone and face-to-face. So some interventions had 3 components. And what we found was that for cessation of exclusive breastfeeding at 6 weeks and 6 months, there was some evidence in favour of interventions delivered face-to-face. And for the other outcomes, there wasn't really any evidence of an association of how the support was delivered. Again, we would advise caution interpreting these results because there were still high levels of variance between the studies. The next thing we looked at was when the support was offered. So this was comparing postnatal support only with support that was delivered in the antenatal and postnatal period. And we didn't find any difference as to when it was delivered. So interventions that provide postnatal support only are likely to be just as effective as interventions that provide antenatal and postnatal support. That being said, that doesn't take into account the actual initiation of breastfeeding. We had planned to look at whether proactive or reactive support interventions were more effective. But all the studies actually included at least one proactive content, so the subgroup analysis wasn't appropriate here, so we didn't undertake that. The next thing we looked at whether background breastfeeding initiation rates had an impact on the effectiveness of the interventions. And as Alison said, there's maybe a bit of a confounder here because the background initiation rate did vary consistently with the income status of the country. And what we found was the 4 studies from the low to low middle income countries had the highest rates of breastfeeding initiation. And all the studies with the intermediate or low background rates of breastfeeding initiation were undertaken in high-income countries. The intervention effect was strongest for exclusive breastfeeding at 6 weeks and at 6 months in studies with initiation rates that were higher. So that does show the importance of interventions that also promote breastfeeding initiation. Interestingly, there was no difference in intervention effect for any breastfeeding at 6 weeks or 6 months according to background initiation rates. The last thing we looked at was the intensity of the intervention. So we grouped the interventions into low intensity interventions, which were studies with less than 4 contacts. The next group was moderate intensity, so that was 4 to 8 contacts. And the final one was high intensity interventions, and that should, read, over 8, i.e. 9 or more number of contacts. Unfortunately, in a number of studies, they didn't actually specify the number of contacts, so we've also got an unspecified number of contacts group. We do advise caution interpreting this result, but what we did find was that for cessation of exclusive breastfeeding at 6 weeks and 6 months, the intervention effect was actually greater for women receiving 4 to 8 contacts. But for any breastfeeding at 6 weeks and 6 months, there was no evidence of a difference in intervention effects. It didn't actually matter how many contacts women were having. Should say here that the differences in these subgroups could also be explained by differences in risk of bias between the studies, with the studies with the more pronounced treatment effects at greater risk of bias, so that's something to take in mind. There was also differences in the settings of visits, with the studies offering more visits tending to be carried out face-to-face, so that might also confound the results. So I'm just going to hand you back over to Alison, who's going to talk about the strengths and limitations and the final conclusions of the review.
Okay, so this is just the last few kind of summing up slides. So in terms of the strengths of our review, there are a large number of trials and participants across all country income settings, and the review is conducted using rigorous methods to minimise bias in the review process. However, there are some limitations. So the reporting of the studies was not always clear. The description of the components of the support intervention, details of the training and qualification of the supporters, the definitions used of the extent of breastfeeding, and in the description of how much the support protocol was adhered to. There was also failure to present details of the interventions and of the standard care available to both intervention and comparison groups. Very few of the trials described a theoretical basis for the intervention tested, with the result that the findings are difficult to explain or to replicate. There's also a possibility that there's publication bias, which means that the smaller studies, those showing a less beneficial effect, may not have been published and therefore may be missing. Of course, as we've described, we're comparing very diverse interventions, and also there's a wide variation in study endpoints. So the implications of this review for practice. So when kind of our overall conclusion is that when breastfeeding support is offered to women, the duration and exclusivity of breastfeeding is increased, and the characteristics of effective support are that it's offered as standard by trained personnel during antenatal or postnatal care. It includes ongoing scheduled visits so that women can predict when support will be available. It's tailored to the settings and the needs of the population group. It can be offered by professional or lay or peer supporters or a combination of both, and that strategies that rely mainly on face-to-face support are more likely to be successful with women breastfeeding exclusively. And the implications for research, well, we know there's been a large number of trials in this area, and that future research could focus on identifying how such support can best be provided more consistently for all women in all countries. So that's around how do we scale up the interventions and what kind of implementation and quality improvement approaches could be used. We also need further research on the training programs for the health practitioners and the lay and peer supporters, and these should be well defined and reproducible. We need to develop a theoretical basis to explain how the interventions might work, because that will help replicate them. and we need to analyse the elements that have impact, such as the training, the timing, the intensity, and the differential impact on different population subgroups. We also need to establish the cost effectiveness of different interventions and to investigate strategies for supporting women who wish to breastfeed for longer than 6 months. So we just looked at breastfeeding up to 6 months, and that seems to be where the focus of a lot of the trials was. But of course, the WHO recommendations are that breastfeeding continues for 2 years and beyond. But of course, that takes long, very long and expensive trials. So we'll stop there, and thank you very much for listening to us, and hopefully we've left a little bit of time to answer questions.
Thank you, Alison. That was a really great presentation, and it's really interesting to hear about the different roles that I guess different types of supports can play with respect to increasing breastfeeding up to 6 months. So we really do appreciate that you sharing this walkthrough with us today, and I am going to just open this polling question, but we do have a couple minutes, and we have several questions that have come in. So just, I guess, maybe to let people know that the polling question is open, and we really would like to know whether the information presented today was useful to you, and whether you agree with that statement. So please let us know as it comes in, and I will just dive into some questions if you two are ready. So there were several questions that came in throughout your presentation that really looked at more of the questions around the risks of not breastfeeding. So a lot of research is framed from a breastfeeding benefits perspective, and we'd really like to know what your thoughts are on whether or not it's okay to kind of turn this around and use the words more like not breastfeeding increase the risks for these types of things. And also in the circumstance where we may not be able to do that, how can we respond to those who state that we can't really switch from the benefits of to the risks of not?
So that's a really good question. It's quite a controversial question, and there are a lot of debates around how to frame that. One of the kind of considerations is that breastfeeding needs to be considered as the normal way to feed a baby, the usual way to feed a baby, and therefore to talk about the benefits of breastfeeding makes it sound like it's an optional kind of extra with a little bit of value added, rather than this is what's the normal behaviour, and it's not doing the normal behaviour that brings risks. So that's one answer to that question. So then I think we have to approach how do we minimise the risks for those who either can't breastfeed, which in physical terms is very few people, or those who aren't in the circumstances to make the decision to breastfeed, or who would prefer not to. Then it's all about how they can safely use other forms of feeding. So that's about minimising those risks.
That's great. Thank you so much. I guess another question that's come in that's a bit similar in terms of the risks of not breastfeeding. So we have a question from Mark that asks, does using breast milk, so even from a donor, decrease those risks? So in terms of that first question regarding expressed breast milk as opposed to feeding at the breast. And a second piece to that, is it fair to say that consumption of commercial infant food preparation prior to the age of 6 months may increase those risks as well?
So if I take the first one, our review, that wasn't something we looked at, was the use of expressed breast milk, whether it's the mother's own milk or donor milk. However, I think there is evidence that any breast milk is better than none. So whether if expressing breast milk is preferable to not giving any breast milk. However, there are advantages to the baby actually feeding at the breast, both in terms of relational, the attachment with the mother, the maintenance of the milk supply around the hormonal processes, and also the sucking action and the development of the mouth and the musculature. Sorry, could you just remind me what the second question was?
I think so the second question was looking more at whether or not the consumption of commercial infant food preparation prior to the age of 6 months might actually increase those risks.
Okay, so the recommendation for the World Health Organization is that babies are breastfed exclusively until around 6 months. So it's partly dependent on individual babies and their needs, but certainly using commercially prepared foods much below, for example, 5 months does indeed increase the risks.
That's great. Thank you. Thank you very much. So we are at our time. I do have 1 or 2 more questions if you'd like to stay on, but I'd also like to just call up our last polling question. There are a few options for ways to interact with health evidence moving forward, and these include visiting our website, registering to receive our newsletter, our registry updates, telling your colleagues about health evidence and the review findings that you heard about today, follow up on Twitter using our @healthevidence handle, encouraging your organization to use health evidence to search for review-level evidence on topics that you're interested in to inform program planning and policy decisions, and suggest future topics for webinars or provide feedback on the series. So I'll just put up the last polling question to let people know what are your next steps, I think is what we really want to hear from you. So whether you're going to access this full systematic review, access the quality assessment, consider ways that you can use this evidence, or tell a colleague about the evidence. So I'll leave that up, and Alison and Anna, if you do have I guess 2 more minutes, there are a few questions here that were really, really interesting questions from the participants.
Yes, that's fine with us.
Yeah, great. So one of the questions is, was there any exploration of what is defined by initiation? So is it just as simple as putting a babe to breast once after birth, or is it putting a babe to breast a certain amount of days or weeks after birth?
Again, that is a really good question, and it's one that is really difficult when you're doing systematic reviews on breastfeeding. So for this review, because we weren't actually looking at initiation, we were looking at support beyond initiation, we didn't actually define initiation ourselves. For the background initiation rates, we were just reporting either what the studies themselves reported as the background initiation rate, or where the study authors didn't report background initiation rates, we looked at other sources, such as those published in the Lancet series on breastfeeding, which was published in January 2017, the UNICEF, WHO figures, or other sources that we could find. So we really are dependent on how other authors and how those statistics are gathered. But I think it is a really important question that initiation can be defined in different ways. And Anna mentioned that there is a move to have a kind of standard set of indicators for Cochrane reviews, and that would include a definition of initiation of breastfeeding.
That's very interesting. Thank you. Thank you so much. So I think one more question that we have here is, did any of the included studies involve online chat or Skype-like video as an intervention, or was it just telephone or face-to-face?
There weren't any online or Skype. I think they were all either telephone or face-to-face. I think one of the things to bear in mind is that there's a time lag between the trials being conducted and published, and then them getting included in a systematic review. So I imagine that in future updates of this review, we might find trials of more what we might consider modern methods of providing support, including online, Skype, social media, those kinds of innovations.
Thank you so much. I think we all really look forward to perhaps seeing that. So we'll keep our eye out for the next update.
I think we need to rest first.
So I do have one more question, if you have some time, and then I think it will be time for us to sign off. But we do have another question that just would like you to comment on perhaps what the number needed to treat for those support interventions when you're looking at those primary outcomes that you were looking at, what that might be or what that might look at, or what your thoughts are on that.
We didn't calculate number needed to treat. That's a good question. I'm afraid I'm just getting over the bad cold, so I don't think my brain could calculate it on the back of an envelope at the moment.
That's fair enough. Well, then, oh, sorry. Was there another comment?
No, apologies for that. No.
Oh, okay. Great. So I think just a little bit over time, but that does bring us to the end of our question period, and I would like to give a big thank you to our presenters as well as to our audience today for posting questions and making this a very engaging and stimulating session. I hope everybody enjoyed being here today. One final reminder that the copy of the recording and the PowerPoint presentation will be posted online in the next week or so, and you can access those at our Health Evidence YouTube and SlideShare accounts. And if you are interested as well, we do have the review and quality assessment of the review on the Health Evidence website and link outs to the full text and supplementary material. So thank you all for joining us today, and thank you, Alison and Anna, for coming in this afternoon. And I would just like to maybe turn it over to you to ask if you have any final words before we sign off.
No, just to thank you for inviting us to do the presentation. We've enjoyed it, and it's a good opportunity to disseminate the findings of our review. Thank you.
That's great. Thank you so much, and thank you everybody for joining. Good afternoon, and have a